Hello and welcome to another Cincinnati Heart Failure lecture series. My name is Mahir Poriyahi. We'll be discussing the part 2 of decompensated systolic heart failure. In this presentation, we'll cover pathophysiology and management. We will barely touch on a few subjects that are essential for better understanding of heart failure and decompensation. These will be covered in a different lecture. But just to quickly skim over, one of these important concepts is Frank-Starling law, assessing cardiac output and or venous return as compared to the right atrial pressure or end diastolic volume, with changes such as overall volume, inotropy, or pressure. It's the ability of the heart to change its force of contraction and therefore stroke volume in response to change in venous return. Additionally, a Wigger's diagram helps put the whole cardiac cycle together in terms of electrical, pressure, and heart sounds. Combining all of these will lead to our commonly known pressure volume loops, which help explain what is normal, what is pathological, and how some of our medications help change these parameters. So left ventricular pressure is plotted against LV volume at multiple time points during a single cycle. One cardiac cycle is divided into the 4 phases: a ventricular filling, isovolumetric contraction, an ejection phase, and then an isovolumetric relaxation. Question asks, what is the width of the loop? Giving you a few moments to think. Stroke volume relates to that. And then you have the end-systolic pressure-volume relationship, which represents the inotropic state of the ventricle. Moving on from this, again, we barely skimmed that subject. We'll assess neurohormonal modulation. So what are we talking about? We've sort of touched on this subject as well during heart failure, the basics of heart failure. But acute neurohormonal activation is a coordinated response. It restores cardiovascular hemostasis in a very short term. The preservation of cardiac output, so salt and water retention, increasing preload, which relates to the Starling effect, an increase in sympathetic nervous system activity, increasing heart rate and contractility, and then increasing systemic vascular resistance, which is critical for organ or end organ blood flow. While temporarily the neurohormonal modulation is essential to maintaining the function of the body, sustained neurohormonal activation drives progression of the heart failure disease. It leads to deleterious effects on circulation and myocardium. The increase in preload creates volume overload, and as such the symptom profile that we are all used to. The sympathetic nervous system activation increases heart rate, leads to tachycardia, increasing myocardial oxygen demand, limiting diastolic filling. The increased vasoconstriction or afterload impairs ejection fraction. And then there is beta receptor dysregulation. I think many of you are used to this figure, but just quickly, this comes from one of the American College of Cardiology review, but it looks at concentric versus eccentric remodeling. And when we're talking about heart failure with reduced ejection fraction, we are kind of focusing on that eccentric systolic heart failure. Sarcomeres are added in series, and it has impaired contraction. The Lynn-Stevenson diagram is really helpful just for quickly think about the disease. If you have a heart failure patient that is well perfused, and is not congested, you have the warm and dry. Hopefully these patients are on the 4 pillars of heart failure therapy, and you're seeing them in the outpatient office. When you get the patients with some congestion, you get the warm and wet. So they might have think about any kind of backup of fluid, whether that's pulmonary congestion, orthopnea, PND, peripheral edema, jugular venous dilatation, or increased jugular venous pressures, congested hepatomegaly, or any other signs of a wet state. These patients might be seen in outpatient clinic, often seen in the emergency department, and sometimes seen admitted to regular tele or inpatient service. When you get to the hypoperfusion state, what is that? That's the cold sweated extremities, oliguria, mental confusion, dizziness, narrow pulse pressure. Think of the shock state. Patients can be either dry or wet, depending on what is playing into driving the current state. Hopefully these patients are seen in either a step down or ICU level of care. What's the clinical course of acute heart failure? So you have the early acute phase, which is the biggest focus of care. And then there is multiple, usually rechecks. So trajectory checks, and you assess for not improved or worsening, stalled or improving. You have the late acute phase, and then the optimization phase with the early post-discharge phase and transition to chronic care phase. Our biggest focus is in that red region right now. So what are some of the medications we utilize for heart failure? As we discussed in the previous lecture, beta blockers, which were initially studied in early 1975s, improve mortality, reduce hospitalization, reversing the desensitization of beta blocker signaling pathway that occurs in a failing heart muscle due to overstimulation. It's not a class effect. You all should know carvedilol, metoprolol, and bisoprolol are the ones that have been shown to have morbidity and mortality protecting effects. In an acute decompensation, it is recommended that we continue beta blockers unless there's a concern of shock state or a low flow state. However, if the patient's not already on it, would not initiate a dose till we deal with the congestion, as that can further set us back in the overall congested state. This is the overall reduced risk of death and reduced hospitalizations for beta blockers. As already stated, do not improve symptoms initially. Patient may require more diuretics. In new onset heart failure, do not initiate beta blockers until the patient is euvolemic or near euvolemic state. I'm going to skip through this, but this is covered in the chronic heart failure section. What about the renin-angiotensin-aldosterone system? We practically have either attacked this system at every level state that we know of, or have shown that some of these were unhelpful. So what are the helpful ones to decrease morbidity and mortality? Angiotensin converting enzyme inhibitors and angiotensin receptor blockers. The proposed mechanism is in reduction in sympathetic activity, endothelial dysfunction, and sodium retention and vasoconstrictions, decrease mortality by about 17%, reduce hospitalization by 30%. Cough is a common side effect in patients that are on ACE inhibitors. Angioedema is less common. Contraindications include pregnancy, bilateral renal artery stenosis, patient that's already hyperkalemic, or has renal insufficiency. Again, I'm going to skip through the trials for this specific lecture. What about Entresto, or sacubitril with valsartan? It's a neprilysin inhibitor and an angiotensin receptor blocker. The neprilysin inhibitor impedes neutral endopeptidase activity on the breakdown of the natriuretic peptides. Neprilysin inhibitor and an ACE are associated with increased risk of angioedema. The paradigm heart failure found statistically significant reduction in primary endpoints of cardiovascular death or first hospitalization for worsening heart failure and then death from any cause. These are quickly some of the medications that we utilize for heart failure and their dosing. This is the number needed to treat for some of the therapies. This also includes MRAs, SGLT2 inhibitors, and the combo hydralazine with nitrates, Vidal, branding. What about aldosterone blockade? Aldosterone is synthesized by adrenal glands. In patients with failing heart, the aldosterone levels are inversely proportional to the ejection fraction. Aldosterone blockade led to an improvement of outcomes of both morbidity and mortality, a 30% reduction in all-cause mortality. These are some of the trials examining eplerenone versus spironolactone. I'm going to quickly skip through Vidal, but hydralazine with isosorbide was utilized and studied, showed genuine effects on morbidity and mortality on Black patients. The patients that were studied in the group were never subdivided to African Americans or Afro-Caribbeans or Africans, so hence why the overall encompassing group. So, and it did show mortality reduction. This is the only drug we utilize when there's an acute kidney injury. You just realize again the overall morbidity mortality effects were only found in the specific racially based population and not in the other groups. How about SGLT2 inhibitors? Pretty well studied in diabetic patients, found to have originally improvement in heart failure symptoms, then further studied on heart failure alone patients. How should we sequence the treatment for heart failure? McMurray actually did a pretty good shift and push for shift in how we do things. The old system was a sequential start. What was found is that we don't get the patients appropriately to the correct medications fast enough prior to discharge. And so a more aggressive start came about or was proposed, which was initiation of usually 2 treatments as a step 1, discharging a patient or late in the hospitalization, starting the patient on the 3rd treatment with either at time of discharge or follow-up final treatment. And then this is to get the patient on the 4 pillars as fast as possible. This is focusing on the mildly reduced EF. So diuretics as needed, SGLT2 inhibitors, which have a 2A recommendations, and then the rest based on other etiologies or what's needed, whether the patient's hypertensive, coronary artery disease, or other things. HFpEF, following a similar thought process. So for HFpEF treatment, SGLT2 inhibitors and risk reduction for other disease processes. So you can consider loop diuretic initiation, MRAs, and ARNIs. So what are the class 3 recommendations? ARNI should not be administered with an ACE inhibitor or within the 36 hours of cessation of ACE inhibitors. And this is why you have the washout period. ARNI should not be administered to patients with history of angioedema. ACE should not be administered to patients with a history of angioedema. In patients taking MRA whose serum potassium cannot be maintained at less than 5.5, MRA should be discontinued to avoid life-threatening hyperkalemia. Up to now, we've covered some of the management for chronic heart failure, which can also be utilized in acute decompensated heart failure state. What about just an acute decompensated medications that we could utilize? Vasodilators, carefully selected patients used to target pulmonary congestion. Patients with hypertension, coronary ischemia, or significant MR may be suitable candidates for the use of IV vasodilators. Nitroglycerin is mostly venous vasodilator except at high dose, and we usually refrain from it due to tachyphylaxis within the 24 hours. Nitroprusside is an excellent drug, potent arterial and venous vasodilator, however needs an A-line, and then excess amounts of it, especially in patients with renal dysfunction or acute kidney injury, can lead to cyanide toxicity. Nicardipine, which is an arterial vasodilator, limited data in use for heart failure patients, might require A-line, increased volume compared to nitroprusside. Not everyone is the biggest fan of this medication, as we already know some of our calcium channel blockers cause harm. The acute use, though, is utilized by many heart failure experts. Here's a list of some of the diuretics and the dose. Really depends on whether we are looking at somebody that's in shock, whether the patient's in the ICU level of care, step down versus regular floor, or for outpatient. So how do we assess IV diuretics? So you start an IV diuretic, initiate an IV loop diuretic early or immediately after admission. Initial dose usually is 1 to 2.5 times total of the daily oral loop diuretic in Lasix equivalents. Prescribe an IV diuretics every 8 to 12 hours. Monitor symptoms, signs, urine output, blood pressure, electrolytes, and look at the trajectory. Is the patient's congestion improving? Continue, or plan to transition back to oral therapy. If it's stalled, then usually further increase it. Consider thiazide-based diuretic. And if it's worsening, escalate diuretics. Consider other decongestion strategies. Consider hemodynamic monitoring, consider inotropes, and consider advanced needs. Is there a difference between continuous versus bolus dosing? The truthful answer is, among patients with acute decompensated heart failure, there were no significant differences in patients' global assessment of symptoms or in change in renal function when diuretic therapy was administered by bolus as compared to continuous infusion, or at high dose as compared to low dose. What about acetazolamide? This wasn't really a well-done study, and they used a lot of restrictions on which patients were included or excluded, so I wouldn't take much guidance from this study. But what they concluded is the addition of acetazolamide to loop diuretic therapy in patients with acute decompensated heart failure resulted in greater incidence of successful decongestion. So again, let's follow our own algorithm. Is there a presence of congestion? So the patient is wet. Is there adequate peripheral perfusion? If the answer is yes, the patient is wet and warm. So we should start some of the chronic heart failure therapy, but consider an increased dose in diuretics if the patient is already on diuretics or initiating diuretics, plus or minus vasodilator consideration. If the patient did not have adequate peripheral perfusion and they're wet and cold, then I think that requires an escalation of level of care, and inotropic plus vasodilators and other expert-based assessment and management might be required. If the patient is not congested and the patient is dry and warm, just optimizing GDMT is essential. If the patient is dry and cold, consideration of inotropes plus or minus advanced therapies should be done. So these patients by this point should have seen a heart failure expert. Again, falling back into what we discussed, warm and dry, warm and wet, cold and dry, and cold and wet. Trajectory checks are important. Improving towards target, continuing towards decongestion, on track with plans of either optimizing or initiating GDMT and discharge, versus initial improvement but then stalled and escalating therapy, considering other options, considering advanced therapies, not improving. Again, hopefully these patients that are not improving, we are either being more aggressive on or considering either advanced or critical care-based management. So, clinical trajectory of patients improving towards the target, great. We're addressing goals of care and educating. We are getting them on GDMT or optimizing their GDMT and addressing comorbidities. Lack of progress, consider higher dose of diuretics or adding second diuretics. Other strategies such as IV vasodilators may be considered. Considering invasive hemodynamic monitoring can be helpful. Reviewing any recent medication changes, reevaluating comorbidities and competing diagnoses. Consulting cardiology or heart failure specialist, plus or minus palliative care is really essential. Not improving, possibly worsening. Consideration of escalation of diuretics, other decongesting strategies, considering hemodynamic monitoring with the right heart cath, considering IV inotropes or pressors, considering percutaneous or durable mechanical circulatory supports, consulting long-term advanced treatment strategies. Hopefully before this stage, these patients have seen heart failure or at least cardiology, reevaluation of comorbidities, and seeking expert opinions. What about IV iron? So in heart failure patients with serum ferritin of less than 100, or in those with serum ferritin of 100 to 300, but with transferrin saturations less than 20%, with a hemoglobin of between 8 to 15, it led to primary outcomes of having heart failure hospitalization or cardiovascular death. And so this is a strategy that we do consider often because of their FIRM trial. What about non-pharmacologic? So we know exercise-based plans, education, diet play a factor in this. These are the recommendations. This graph should just make sense. This is in-hospital mortality in patients with normal or low blood pressure and normal versus elevated serum creatinine or worsening kidney function, if you want to look at it that way. We talked about exercise, but this is the recommendation for exercise-based training in patients with heart failure. Some of the other risk models, like Seattle Heart Failure Risk Model, can further risk stratify patients and also sometimes show patients what each therapy does to their overall morbidity and mortality. We won't really touch this subject, but we'll start the conversation about if the patients are decompensating, they don't have adequate forward blood flow, their systolic blood pressure is falling, and they have decreased mentations, cold extremities, decreased urine output, elevated lactate, we need to talk about cardiogenic shock. This will come about in future lectures. Thank you so much for joining us. It's been a pleasure to have you guys here.